Hello everyone, we are from Group 2A consisting of me, Alfriani, Hamizan Hafiz, Dayanur Amira, Cindy James and Rebecca Anggun. This is the outline of our presentation, which includes introduction, case presentation, disease process, management and outcomes, and lastly, nursing care plan. So the case study we chose was infective exacerbation of bronchiectasis. This case is really interesting because the term exacerbation itself has different thresholds in defining it based on its etiology, symptoms, and it is challenging to start the clinical management of treating exacerbation of bronchiectasis. According to Amati et al. 2019, bronchiectasis is heterogeneous not only in a stable condition but also during exacerbation. It is remained poorly understood despite evidence on clinical and biological aspects of bronchiectasis. However, through this case study presentation, the audience will know how this patient is diagnosed and treated according to the medical conditions she is experiencing.
The patient's biographical data that we chose was female. She is 67 years old, belongs to the Malay race, practices Islam, works as a farmer, and is Malaysian. The chief complaint was the patient complained of shortness of breath. The patient tried to relieve her shortness of breath with an inhaler, anti-salbutamol, but could not resolve it. So, she decided to went to the hospital. The presenting symptoms she presented were productive cough with whitish sputum for 1 month since discharge previously on 16 November 2022, which worsened for 1 day, and had shortness of breath for 1 day. Otherwise, no fever, runny nose, chest pain, sick contact, TB contact, or hemoptysis. The past health history was the patient has underlying hypertension, diabetes mellitus, dyslipidemia, and bronchial asthma. She had a history of admission on the 10 August until 13 August 2022 for bronchiectasis, which also gave her influenza and pneumococcal vaccination upon discharge. She has another history of admission on the 17 October till 22 October 2022 for infective bronchiectasis and history of recent admission on 9 November until 16 November 2022 for infective exacerbation for bronchiectasis, with resolved septic shock and fast atrial fibrillation. She has vaccinated COVID twice and shown negative RTK for COVID, and the patient has no family history of asthma. The assessment finding at ETD was she was able to speak in full sentences. Her blood pressure is 135 over 75 mm of mercury, which is considered normal since she has hypertension. Her heart rate is 126 beats per minute, that shows tachycardia. Her respiration rate is ranging from 36 to 40 breath per minute, which shows tachypnea. Her oxygen saturation is ranging from 71 to 84% under room air, which is low and concerning. Her temperature is 36.7 Celsius with full GCS of 15 over 15. Her lungs were generalized bronchi with equal air entry, and she was given IV hydrocortisone 200 mg stats and IV tazocine 4.5 grams stats. Her ABG under room air is pH of 7.30, which is acidic, partial pressure of oxygen 45.2 mm of mercury, which is very low than normal, partial pressure of carbon dioxide 61.7 mm of mercury, which is higher than normal, bicarbonate is 39.3 mmol per liter, is little higher than normal, oxygen saturation of 75% lower than normal, and this ABG interpretation shows partially compensated respiratory acidosis. She then started on BiPAP with fraction of inspired oxygen 0.3, expiratory of positive airway pressure 10, expiratory positive airway pressure 5, in view of carbon dioxide retention and tachypnea. Post-ABG under BiPAP is pH of 7.33, which is slightly acidic, partial pressure of oxygen, which is 81.2 mm of mercury, is normal, partial pressure of carbon dioxide of 56.5 mm of mercury, which is still high, bicarbonate of 39.1 mmol per liter, which is a little higher than normal, oxygen saturation of 95%, which is normal. The post-ABG under BiPAP interpretation is still partially compensated respiratory acidosis. She was subsequently weaned down to nasoprong 2 liter per minute. Her chest X-ray shows bronchostatic changes and ECG shows result of sinus rhythm. Her progress in work was she was able to wean down to room air subsequently. Blood culture and sensitivity was taken on the 9th of December, so far as no growth. Sputum culture and sensitivity was taken on the 10th of December, that was still impending upon discharge. Smear acid-fast bacilli was taken on the 10th of December, resulting no acid-fast bacilli shown that the patient has negative TB. She was given IV tazocine for 5 days from 8 December to 12 December 2022. To summarize the results of clinical examinations, the patient came to the hospital presented with shortness of breath and productive cough with whitish sputum. Her oxygen saturation upon arrival at ETD was ranging from 71% to 84% under room air, with respiration rate ranging from 36 to 40 breaths per minute. Her lungs generalized bronchi with ABG interpretation showing that she had partially compensated respiratory acidosis. The patient's final diagnosis was infective exacerbation of bronchiectasis secondary to hospital-acquired pneumonia. That's all from me. I'll pass this to the next presenter. Thank you.
Bronchiectasis is a long-term condition in which the areas of the lungs become widened, resulting in the buildup of excess mucus that can make the lungs more prone to infection. Meanwhile, bronchiectasis exacerbation is defined by an increase in daily respiratory symptoms such as cough, sputum production, malaise, fatigue, and breathlessness. What's the difference between bronchiectasis and bronchitis? Bronchiectasis and bronchitis have similar symptoms, including mucus in the lungs and coughing. But bronchiectasis causes permanent widening of the airway, while bronchitis is a temporary infection that doesn't cause lasting damage. The airway or bronchi that go into the lungs have defenses to protect the body from disease. Mucus is one of these defenses. When mucus cannot be coughed out, it causes lasting damage to the airway. When people breathe air in, any harmful particles get trapped in the mucus in the airway. The mucus is then moved out of the lungs by millions of tiny hair-like structures known as cilia in a coordinated motions. This is called mucociliary clearance. People cough out the mucus or swallow it, where the trapped particles are destroyed by the stomach acid. When any part of this system fails, for example, if the cilia are injured, mucus can build up in the lungs. The mucus has bacteria trapped in it which can multiply and cause infection. The damage caused by infection might exacerbate bronchiectasis. People who is living with underlying condition that affects the lungs or immune system has higher risk of getting bronchiectasis. In this case study, the patient has been diagnosed with bronchial asthma since she was a child. Due to this condition, the patient has higher probability of getting bronchiectasis in the older age. In 2022, she has been diagnosed with bronchiectasis and has readmission history before the recent admission. All the admission is due to the disease of infective bronchiectasis. The patient appears with productive cough along with whitish sputum. The patient also verbalized that she sometimes experiences shortness of breath.
First, I will talk about the plan of care and also outcome for this case study. As the patient initially was presented to SGH ETD on the 8th of December 2022, the condition was indeed concerning as the patient had a respiration rate of 36 and the SpO2 was only 84% under room air. The ABG under room air results indicating that the patient had type 2 respiratory failure, which indicates that the patient had hypercapnia. The patient was started on BiPAP for 3 hours in the ETD and then went down to nasal prong 1 liter per minute. The patient was also given IV hydrocortisone 200 mg and IV tazocine 45 mg. The patient's chest X-ray indicated that there is a bilateral perihilar haziness plus bronchiectatic changes present. Next, throughout patient's hospitalization in the ward, the patient was also given IVD maintenance 1.5 liter per day, all normal saline plus 0.5 kcl. The patient was also prescribed to be given nebulizer AVN 6 hourly and nebulizer VN when needed. The patient's condition has improved as the SpO2 levels progressively increased and maintained more than or equal to 92%. After discontinuing nasal prong 1 liter per minute, the SpO2 recorded as of 11th of December 2022 was 97%. According to Langley and Cunningham in 2016, the normal range of SpO2 should be of 94 to 100%. Moving on, I will be presenting on the indications of how and why the treatment is discontinued or finished. During hospitalization, the patient was given nasal prong 1 to 2 liter per minute as the SpO2 level recorded were only 84% under room air. On the 9th of December 2022, the doctor had monitored her SpO2 level with and without oxygen therapy, and it was recorded that the patient's SpO2 level with nasal prong 1 liter per minute was 98% and 93% under room air. The following day, the doctor continued to monitor the patient's SpO2 level again, and it was recorded that with nasal prong 1 liter per minute, the patient had 99% SpO2 level and 95% under room air. Hence, trial to off oxygen therapy and keeping it within 88 to 95% was conducted as ordered by the doctor. On the 11th of December 2022, the doctor had also discontinued nebulizer AVN for the patient for 8 hourly. According to the National Capital Poison Center, there is evidence that excessive albuterol use can aggravate asthma overall, increase the number of days with asthma symptoms, and increase the number of asthma episodes. Hence, the doctor discontinued the nebulizer AVN that is usually given to the patient 8 hourly. Finally, I will be discussing regarding this patient's discharge plan. The patient has been scheduled to be discharged on the 12th of December 2022. For this patient's discharge plan, the doctor planned for this patient for an outpatient HRCT thorax and to come again to the discharge clinic at MOPD SGH in 1 week's time. After the HRCT thorax, to review and to trace the blood CNS which was taken on the 9th of December, the sputum CNS which was taken on the 10th of December, and to keep in view the patient to be referred for respiratory follow-up. Therefore, the medications that this patient received upon discharge are Respimet tiotropium 5 mg taken once daily, MDI salbutamol 200 mics when taken when needed, tablet metformin 500 mg taken twice a day, and tablet bromhexine 8 mg taken 3 times a day. That is all from me. Thank you.
In the first nursing care plan, the nursing diagnosis that are prioritized is ineffective airway clearance related to excessive mucus secretion, as evident by a productive cough with whitish sputum. For the goal, the patient will be able to maintain a patent airway within 3 days. As for the intervention, the first intervention is to assess the airway for patency, such as change in voice and noisy breathing. For the rationale is to understand the status of patient airway patency and identify any abnormalities that warrant immediate action. The second one is educate patient on deep breathing exercise and coughing exercise to lose the secretion, the excessive amount of secretion from airways. For the third one is position the patient in semi-folio position, which will allow better lung expansion and improve air exchange. And the fourth one is to maintain humidified oxygen as prescribed, to reduce the thickness and lose the secretion in airway. And finally, they encourage patient to drink more water to reduce the thickness of secretion. As for the evaluation, the patient was able to maintain a patent airway within 3 days. For the next nursing care plan, the nursing diagnosis that we come up is ineffective breathing pattern related to bronchiectasis, as evident by shortness of breath with oxygen saturation of 93%. The goal is the patient will be able to maintain an effective breathing pattern within 3 days. For the intervention, assess and record respiratory rate at least every 4 hours to identify any abnormalities such as alteration in breathing patterns. The second one is position the patient in semi-polar position to allow a better lung expansion and improve air exchange. The third one is educate patient on deep breathing exercise to maintain a patent airway. And the fourth one is encourage patient to use an incentive spirometer. The rationale behind is to prevent lung infection by expanding the lung and strengthening the lungs. And the final one, administer medications such as atrovents as prescribed to help relaxing the muscle around the airways and allow patient to breathe more easily. For the evaluation, the patient was able to maintain an effective breathing pattern within 3 days.